So ladies and gentlemen, we now begin the Phaconightmare course. And basic idea here is, I'll start with a little bit of the basic stuff, and then as we progress, can I have the signal on? Thank you. And can we have these lights a little bit dim? And then let's see how the game goes. Remember, after this you all have lunch, so please don't blame me, okay? Because this is not going to be pretty. Let's see the first case. Now, in this particular case, which I'm going to show you, I want to show you all how to do basically a glued intraocular surgery. And one of the problems is, what if you have a larger eye? Now, you get children like this who have Marfan's. Now, these are all progressive conditions. If you try to fix them with endocapsular rings or this or that, what is going to happen is, I tell you what, some years down the road, they will lie on the retina. When you have a pseudo-exfoliation or something like that. So now, I'm measuring the white to white. Now, once you measure, always go for the shortest distance possible. So if the shortest 11 millimeters, let's say, is vertical, and 12 millimeters is horizontal, go vertical. Here you can see I'm making my vertical flaps. Here, once I made 3 cuts, I'm now going to take the same one which you make for SICS incision, from one end to the other, pull it out, and your flap is made. So that will take you about very less time to make one flap. So you see 3 cuts, 1 cut, 2 cut, 3 cuts. Once the 3rd cut is made, pass the blade from one end, take it out to the other, and you can see here, we will now pull it out. If you can have these lights off, it'll be much better off if you can off those lights there. AV people, can you off those lights there because they're not needed. Now, the next step is always have fluid in the eye, okay? So you can use a trocar retina cannula here, and I'm fixing that inside. Once I have got that fixed, I will have constant fluid in the eye. Next step, once you have done that, I make 2 side port incisions, okay? Now remember the next very important step, I told you this is a large white to white eye. So what am I going to do is, I'm going to do a small iridectomy. So I'm doing a vitrectomy first, and subsequently you'll see a small iridectomy being done. Look at the area of the scleral flaps. That's where I'm doing the iridectomy. So you can see here, small iridectomy done there. You can see that. Why am I doing the iridectomy? The reason is very simple. When I do this small iridectomy, and you can see that being done on the other side also, I can make a sclerotomy. Remember the number 22 gauge. But I come very anteriorly, about 1 millimeter from the limbus, and go through the iridectomy. So you can see I'm going to now go make it through the iridectomy. Look at that, 22 gauge needle, goes through the sclera, goes through the iridectomy, and now you can see that in the vitreous cavity. Once you have done that, remember the next step is, I'm going to do a lensectomy. I don't need that lens. All it will do is give me aberrations. So what am I going to do? I'm going to knock off that lens fully, and for that I can do a lensectomy, vitrectomy procedure. When you go near the iris, be careful, because what will happen now at that stage is, when you're going near the iris, what can happen is you can chew up the iris. So at that stage, stick to more of aspiration, and you are better off with that aspiration mode at that stage. So far, so good. Now, ladies and gentlemen, we now make an incision of about 2.6 or 2.8, whatever you have. Now you take your intraocular lens, any 3-piece IOL of your choice. I prefer to use an AMO 3-piece IOL, but you can use any lens, but I suggest use an AMO injector. The reason is, the Alcon lens is good, but the injector does not give the control. In a 1-piece foldable, it gives a very good control. In a 3-piece, it sometimes comes upside down. Now watch carefully what I'm doing now. I have got the haptic a little bit out. So I'm passing the glued IOL forceps inside there. And now watch. I'm going to catch the tip of the haptic. Look at that. I have caught the tip. So far, so good. Now once I have caught the tip, this is a rotating type of injector. If it is a plunger mechanism, you can just use your finger and plunge. But if it is a rotating mechanism, ask your assistant to rotate. So your assistant is rotating. Wait for the lens to unfold. Nothing will happen. Where will this lens go? You are holding one end. The other end is outside. Nothing will happen. Wait for that lens to unfold. Once that lens has unfolded, pull out. So you can see now, one haptic is already out. Once one haptic is out, take the second haptic, and you can do the no assistant technique of Dr. Narang, in which I am flexing it inferiorly so that this haptic comes out. This way, you don't need an assistant. So once it's done, watch carefully. I'm shifting from the one hand to the other. This is the handshake technique. Now once that's done, the first hand goes through the sclerotomy, through that small iridectomy which you created, catch the tip of the haptic. Once the tip of the haptic is caught, pull out. And you can see, lo and behold, you'll see both haptics out. Now once you have both haptics out, see carefully. How much of haptic is externalized? Look at that. Because I came anteriorly. That's a 12 millimeter eye. Think, if I can tuck this haptic inside this much, there is no way this intraocular lens will dislocate ever. This is a young child, let's say 5-year-old, 10-year-old, whatever it is. This child has got a 70-year lifespan. Let's give an example. This lens cannot dislocate. So now, once you have got that, what my next step is, I take a 26 gauge needle. Watch that. That's a 26 gauge needle. And I create a tunnel there. That is the Gebor Chariot's pocket. Because this great system was started, first of all, by Gebor from Germany. And I tuck the haptic inside the tunnel. You can tuck as much as you want. It's up to you. The idea is simple. You need to center the lens. Now remember, when I'm doing the other side, watch my left hand is here. I'm holding the sclera. I'm not leaving it till I tuck. Now, second haptic tucked. Now that is game, set, and match. That both haptics are through. Now inject intraocular pilocarpine. Check. Do you have any optic capture? If you have, we will solve it. But in this case, there is no captive iris. There is no optic capture. If there was, I will do a single pass 4-throw pupillasty, and I'll come to that later on. So ladies and gentlemen, very simple. Stromal hydration done. Put air. Check, is there any optic capture with air also? There is none. If you don't get optic capture when you inject air, and I'm repeating it to all of you, with air there is no optic capture, you will not get an optic capture. Now, apply the fibrin glue. Another reason why I'm putting the air is, I don't want hypotony, because now I've removed the fluid or the infusion cannula. So now I apply the fibrin glue, seal everything down, and you can see now the case when it is completed. Use the same fibrin glue for the clear corneal incision. Post-operative day 1, ladies and gentlemen, you can see the patient how it's looking. 2 weeks post-op, patient is already 20/20, and you can see how this patient looks. Now, saying that, since we first showed what a simple case of glued IOL is, let's move on to another very important thing, because this is something, again, I believe everyone in this hall will face a problem. And how do you manage this? And that is something which Prakash showed a little bit on also, but let's see it in more detail so that we make it easy for everyone here to do. Now, patient comes to you like this with a PC rupture. There is a rupture, but when the rupture happens, there is a fragment also there. So now, simple way is, first bring your fragment anteriorly. So watch carefully. What I'm going to do now is, I'm doing some vitrectomy, bringing the fragment anteriorly, place it above the iris. Once it is above the iris, I am safe. Now, my problem is, if I go in with a phaco probe, that fragment can sink. So what am I going to do? Inject a 3-piece IOL. Remember the word? 3-piece IOL. Don't inject a single piece. Inject a 3-piece IOL, and you can put one haptic into the sulcus. You can put one above the iris. You can keep one haptic out. You can keep both haptics above the iris. Call is yours. Okay? Once you have done that, take the phaco probe. So what have you effectively done? You have created your own posterior capsule. In other words, basically here what you are doing here is, you have created your own posterior capsule, and this becomes a scaffold. So now, before you can say bingo, you will see that fragment gone. Can I have a microphone here for him? Yes, also. Now, once that's done, now all you need to do is take the haptic, put it into the sulcus if it is there. If you don't have sulcus, same lens can be glued in. So let's see this again. See the patient now. Same patient I showed you before, and if you remember in the animation, we had this case in which I'm doing my vitrectomy, fragment is down, but all I'm going to do is, there's a tone rexis. Watch the tone rexis there. So all I'm going to do is bring this fragment anteriorly up. Once it is up and above, all I'll do now is implant a 3-piece IOL. Once we have implanted a 3-piece IOL, you will see here it is going very safely and comfortably inside. And there you can see the haptic going inside. Once my haptic goes inside, look carefully, it's going above the iris. Now wait for that lens to unfold. Once that's done, my other haptic I can put into, again, above the iris. Alternately, I can keep it outside. Call is yours, whichever way you're comfortable in. But remember, this lens cannot go down, so don't get worried. Okay? In this case, I always have fluid in the eye. I'm centering that lens with my left hand, and with the phaco probe now, as I showed you in the animation, before you can say bingo, that fragment is gone. So, simple way I've done is an IOL scaffold. Now remember, I have a good rexis, partly at least. All I can do is implant it into the sulcus. Nothing. How much time would this take for anybody? And this patient was post-operatively 20/20 vision. Now let's say I did not do that. If I had not done that, the problem is, this is what will happen. I would have had a drop fragment, and that is risky. So instead of creating this unnecessary complication, the IOL acts as a scaffold, and once you have that, you're much safer. Let's take slightly more difficult case. Patient has got a posterior polar cataract, and this is a dense posterior polar cataract. When such cases happens, I've done my rexis, I'm doing all my hydrodelineation, but invariably when you remove the nucleus, sometimes, in this case, you see my epinucleus, there was a rent, and my epinucleus started sinking. So now, I have again a same problem, where I've got a thick epinucleus, but it's about to be sinking there, because there's a huge rent present. Now in such cases, what do I do again? I'm stuck. In this case, I fixed an AC maintainer. Today, you can use a trocar AC maintainer also. My idea is very simple. I'm going to bring the fragments up. But the reason I'm showing you this clip is for another reason. Watch the iris and the pupil. Because of the prostaglandin release, the pupil has shrunk and the pupil has come down. Now again, I inject the IOL above the iris and I've created a scaffold. Now I go in with the phaco probe and you can see I've removed the epinucleus very safely without any problems. But now watch. What is the problem you face here is, I have a small pupil. I do not know how much rexis I have. I really don't even know if I have a rexis or I don't have a rexis. So what do? I don't know where I am. When you do not know where you are, simple solution, dilate. So I'm using iris hooks to dilate the pupil. And you can see me doing that. Now I go in with my vitrectomy. I see some peripheral cortex, which I could not have seen when the pupil was not dilated. And you can see there, once I have done that, you will see subsequently, I can now implant the IOL very comfortably above my rexis. And that is what I'm trying to tell everyone here is, if you are in a doubt, use the iris hooks, Now I can inject intraocular pilocarpine, bring my case back to normal, and look at the patient 1 week post-op, the patient already is 6'9" or 6'6". We published our study with on this in the ophthalmology journal also, with Dr. Narang also had published this, helped us in our journal on that. Now let's take this difficulty slightly more. Okay? Now you're operating a patient, and watch carefully what's happening. I have a rent. Now in such a case, I will first of all fix a trocar AC maintainer. This is the trocar AC maintainer which goes from the sclera and goes above the iris. Now I make my 2 scleral flaps. I go ahead, make my sclerotomy as I showed you just now, but the reason I'm showing you now here is I'm doing my vitrectomy. Now I take my fragment, bring it up, and implant the IOL. So far so good as I've shown you, but the reason I'm showing you this clip is I've done my scaffold. Now in this case, if I don't have a capsule, what do? I use my iris hooks, remove all my cortex, now do the handshake technique which I showed you previously, and the same intraocular lens which is above the iris will start going behind the iris. And in other words, I'm converting this into a glued intraocular lens. So ladies and gentlemen, we did basically 1, the PAL technique where I brought it up, 2, I did the scaffold, and 3, I did it a glued IOL. So in other words, this is the triumvirate technique, where you're using 3 techniques in 1 surgery. So once I have done that, if needed, I will do the single pass 4-throw pupilloplasty. And I'm going to talk on this much more so that the patient will not have any optic capture. This single pass 4-throw pupilloplasty, which I'm showing you the animation, is such a simple procedure which perhaps everyone in the audience, when you go back to your OR, if you have not started it, you will be able to perform it very, very comfortably. And you can see that's how the case looks when it's completed. Take off the trocar AC maintainer, seal everything down with fibrin glue, and you can see case completed. Now let's see that, since I've shown this to you. Let's see that in an actual particular patient for us to analyze and see, because it's important that these patients with a posterior capsule rupture, how they can be managed if the difficulty is increasing more and more. So let's see this particular case which I'm going to show you just now. I'm started my phacoemulsification, and watch in the middle, tuck, there is a rent, and there is a PC rupture. Watch the vitreous. There's a lot of space in the front for those who are in the back. Please come. The carpet is lovely, or you can take some chairs right here. Okay, you can take even these here, and Gaurav and me can sit on the floor also, no problems. Okay, so those in the back can come in the front, and we'll be showing you more challenging cases. So those in the back can come in the front and even sit on the carpet also. I'm sure it's very nice. So once I have got this problem solved, watch carefully now. My first solution is fix a trocar AC maintainer. This trocar AC maintainer is made by Mastel in the United States. Look carefully, it goes through the sclera, 0.5 millimeter from the sclera, then I rotate. It's like the retina trocars, but it is a trocar AC maintainer. I've got a fluid inside the eye. Now look carefully, if I had to fix a retina trocar, I can't even see whether my retina trocar is going to hit the subchoroidal space or not. So in the trocar AC maintainer, I'm very comfortable. When I will pull it out, it's a valve. It's a trocar, so it just comes out very easily. Now I can make my flaps, because when you make flaps in an eye which is solid, it's easy. Watch now, I made my sclerotomy. Now watch, I'm going to do the PAL technique. So I'm going to lift my fragments up and bring them above the iris. Once I'm above the iris, I'm safe. Now I think, hold on, at least these fragments will not go down. So now I do some more vitrectomy. Now once I have done that, look carefully. My next step is to do the second part of the triumvirate, and that is the scaffold. So now I'm going to inject the IOL. So watch here. In other words, you are implanting an IOL before the nucleus has been removed. That's the basic game plan. I've implanted my IOL there, placed it above the iris. Once that is done, now I go in with the phaco probe. I've done some vitrectomy. Remember, there's no vitreous there. Now, go ahead and knock off these fragments. Once I have knocked off these fragments, you will see one by one all the fragments coming out. Once you see this, look, I'm safe. I have my own posterior capsule. Okay, I've got a fluid going in from the front and from the back also, from both sides. Now I go in with my vitrectomy probe. It's easy to remove cortex. The challenge is to remove nucleus. Now again, watch. I don't have a great pupil. My pupil is small. I am really not sure where I am. In such cases, I have a doubt, I will dilate. So I dilate the pupil with my iris hooks, and you can see me dilating this pupil. Once I'm dilating, then I'm very comfortable, and you can see here, I'm going to go and remove all of this cortex which is present, slight epinucleus present, but I'm very safe and I'm very comfortable because I'm always bringing it in front of the intraocular lens. So far, so good. Once you have done that, I can go behind that iris using an iris as a spatula there, repositor there to prevent my iris getting chopped also. Again, that was published in the IGO also. Now, ladies and gentlemen, I have done my nucleus removal. Now, we move to the third part of the triumvirate. I have to shift this IOL because you obviously don't see any bag worth the salt. So what I'm going to do, shift this intraocular lens, which is lying above the iris, to behind the iris. So using the handshake technique, catch the haptic. Now once I've caught it, I'll remove all this muck which is present there so that there is no addition present. In other words, a PC IOL in the AC is converted to a glued IOL. I'm doing the second one. Same one. Both haptics have been secured. Now take off the iris hooks. Now check how much haptic is externalized. Look at how much haptic externalized. It's a lot. There is no way this haptic is going to dislocate if you see that much haptic. When I see patients sometimes with the haptic dislocated, check, you've gone too far back. So many surgeons go very posteriorly, so the amount of haptic which is externalized is very less. When it is very less, you will have a problem in your hand. So now, once I've got that haptic tucked, again, second haptic tuck. Look at the advantage of the glued IOL is nothing. I can tuck, I can untuck. I can tuck, I can untuck, depending on what I want. If I have a multifocal IOL, I can center my multifocal IOL exactly where I want it to be. In other words, you promised a patient a multifocal IOL. Can you deliver if he has a PCR? The answer is yes. If it's a 3-piece multifocal IOL. Once you have done that, now I'm going to check, do I have a good pupil or do I have optic capture? I'm injecting triamcinolone inside that eye, checking any vitreous present there or not. Now look, I've injected intraocular pilocarpine also. Seeing my pupil, I don't see an optic capture. If I don't see an optic capture, I'm comfortable. All I need to do now is apply the glue and seal everything down. All people from the back can come in the front. There's still some place here. And you can see now, in other words, we have published this also in the Journal of Cataract and Refractive Surgery. Saying that, ladies and gentlemen, now let's move to something very interesting. And this is something which I think I need to talk to you about. But before I move on to this, a few comments from Gaurav Luthra, who's chairman here with us. In IIRSI, he was the president and also the ARC at present. So what is your take on the scaffold or the glued IOL techniques?
So I think scaffold has really been a game changer because, in the past we would have these, if you had a PC rent and you had still some nucleus which was still in the chamber and you were then wondering what to do and you would, be at a loss. Most of the times you would try to manipulate it to one side or the other and try to eat it off in the antechamber, and you would have, eventually you would always have a nucleus drop or at least a fragment drop. So now, the moment you have a PC break, and if you feel that it's big enough that you will not be able to handle it, and you still have a piece of nucleus anteriorly, the first thing you should probably do is put in a 3-piece lens and create a scaffold. It really, really changes the way you manage these cases, and you can get away with almost 100% of your cases without a complication. So I think the scaffold has been, and I think it's universally accepted now all over the world. Where I travel, I see people are using the IL scaffold, which was described by Dr. Amar. Now the other thing which I am enjoying a lot is the single pass 4-throw. It has again made life so easy for us. We used to struggle with all those funny knots, and we would end up not even doing those surgeries because we were not comfortable using the other seep-search techniques and other techniques. Now this is such a simple technique, almost anybody can go home and the first patient you'll try it, you'll probably be able to do it. You just have to find the right place to pass the suture, and then the knot itself is so easy. It's self-slipping, it just goes in, you just pull on it and it goes into place and it locks on and it's there. So I think the single pass 4-throw has again been a transformation, and I'm sure sir is going to show the pinhole pupilloplasty after this, but so I won't talk about that. But these techniques have really, really changed and made life so much easier for us.
Thank you very much, Gaurav. Can we have the lights off, please? So, Gaurav was talking just now, can we have these lights off? On the single pass 4-throw pupilloplasty. So let's watch this carefully now. And this is important, all of us. Let's catch the animation and then we'll show you the surgery. Game is on. Okay, when you are doing, you have many techniques. You have the McCannel, you have the seep-search, you have the circlage. There are many techniques. What this technique brought forth was this: single pass 4-throw pupilloplasty. So watch carefully now. You are going to use a proline suture. Use a 9-0 or a 10-0 suture. Now watch now, I'm holding the iris. Now pass a needle, straight needle, through the cornea, through the iris. Leave it. From the other side, catch. Now you have a clear corneal incision. Remember that. So pass a 26 or a 30 gauge needle, pass it through the iris. Now, ladies and gentlemen, railroad the two. Now, once I have railroad the two, bring it out. Now, once you have done that, bring the loop out of the clear corneal incision. So, remember, this is single pass. Now, remember the number 4. So, pass the suture 4 times through the loop. Now, you see 1. Now, I go 2nd. Now I go 3rd, and then I go 4. Once you have done 4 times, pass one end of the suture on this end, pass one end of the suture on the other end, pull. And that is again game, set, and match. So you can see there, take a micro scissor, cut. Now you can do the same on the other side, and you can see here, both sides pupil completed. Now let's see a particular case. This is a case of Uret-Zavalia. Just to update everyone, believe it or not, this was discovered in 1963, and very few cases have been reported in literature, but there are a dime a dozen. When you go back to your OPD, check your patient. There is a patient, you've done surgery, but the pupil is dilated, and you're scratching your head and thinking, why is this pupil dilated? Or a patient having closed angle glaucoma, 50 IOPs. Then you say, I'll do a trab, I'll do a valve. Don't do anything. All these cases simply need a single pass 4-throw pupilloplasty. This is after gluteal. Patient comes to us with a Uret-Zavalia syndrome. Now, Uret-Zavalia syndrome can be with glaucoma, without glaucoma. This was without glaucoma. Fixed fluid in the eye. Now, I'm making a side port incision. Take out the bubble. So, I keep a vitrectomy probe always in hand. Now, watch carefully. Catch with the gluteal forceps the iris. Now, take a needle. Watch me through the cornea, through the iris. This is either a 9-0 or a 10-0 suture with a straight needle. On the other side, I've got a 26 or a 30 gauge needle. Goes through clear corneal incision, enters into the iris. Railroad the two. Bring it out. Simple. Once it is out, now let's see the game. Once that's out, I'll bring this loop out. So see, now I'm trying to create the loop. That's the loop there. And you can see now, I'm trying to do the single pass. So this loop comes out through the clear corneal incision. This is single pass. Now remember the number 4. So I'm passing it 4 times. Once I passed it 4 times, I pull both the ends and you can see the pupilleplasty completed. Now remember, if I would do something else, I'll do second pass. I'll do a third pass. So people do, let's say 3, 2, 2 or something like that. Every time you do a pass, you can hit endothelium, you can hit iris, you can hit IOL, and you can have a problem. Once I've done on one side, I can do on the other side. And either way, even this can be closed. So just depending on how many you want, but look at the pre-op, and now look at how the patient is looking post-op. Completed. Simple. Anyone can do it. It's so simple. But I suggest people use fluid. Now let's take this difficulty slightly more. Okay? I have a patient with penetrating keratoplasty. Patient has got Uritzavali. And I tell you what, there are lots of such patients. PK, you have done beautiful PK. The iris has gone dilated, stuck, closed angle glaucoma. How do you know it's closed angle glaucoma? Pressure is high. You're wondering what's the anterior segment OCT? It's stuck. Okay? Once you have a closed angle there, then I'm thinking, hold on, what's going on here? This patient's pressure has gone to 40 something. It's absurd numbers. Okay? So what can I do? Simple. I'm going to try to solve it with the single pass 4th row pupillasty. Now I'm going to break those synechiae, open the trabecular meshwork so that that closed angle will become an open angle. And that's what we are trying to do. So you can do a 4-point traction or a 6-point traction depending on whether there's 270 degrees or less of peripheral anterior synechiae. Now, again, fix a trocar AC maintainer, always. Why? Believe it or not, when you break those synechiae, there will be bleeding. Because there are long-standing, some cases might be there. Always the fluid will just keep on pushing the hyphema away. Now watch, I'm going to do the single pass 4th row pupillasty. You can keep on doing it how many ever times you want, but simple game plan is simple. I am going to try to make my angle open. So here you can see now my loop coming out. Once that loop comes out, now you all know the process. 4 times I will pass it, bring it out. Let's see how this patient behaved post-operatively. Let's see. So once I have done that, you can see my pupil coming back down. Imagine it was fully dilated, and these patients who are blind, look at them, okay? Preoperative hand movements, intraocular pressure was 30. Look at the anterior segment OCT, and look at that, fully open. Pre-op, post-op. And you can see the huge difference this is making. Now let's take this slightly more. There are retina people here, and we have published this, and I think it was also shown in the retina sub-day. Patient has silicone oil. A lot of patients will come to you, oh, silicone oil in the eye, what do I do? Okay, pressure is gone, I remove the silicone oil, pressure is still high. The reason is, there is a Uritzavalia here again. Look, I remove the silicone oil, but look at my peripheral iris, it's stuck. I'm going to do a single pass 4th row pupillasty. Look at this, preoperative, look at the cornea clearing. Look at the angle, anterior segment OCT, 1 month post-op. You look at the comparison of this and you will see the huge difference. Now question comes, okay, I want to examine the retina post-operatively tomorrow. Can I do it? Can the pupil dilate after 4th row pupillasty? And this was published in the October issue of JCRS. You can see, I'm not saying it dilates a lot, but yes, it can dilate if you do 4th row pupillasty. If you are doing a cerclage, it will not dilate, definitely. Now let's take the difficulty slightly more. What if I'm combining it? I'll show you some videos on it with glued IOL and pre-Descemet's endothelial keratoplasty. This case was referred to me by our president of the AIOS, Dr. Natarajan. She had been operated 6 times. She was about to commit suicide, and that was the pre-op, and that was the post-op picture, and you can see the difference. Tomorrow, ladies and gentlemen, in Hall A, we have the Ophthalmic Premier League at 12 o'clock. Believe me, you will enjoy it because it's going to be covering up various such topics also. Now look at another picture which I wanted to show you. Failed penetrating keratoplasty. One-eyed patient. This was the only eye of the patient. Okay? What did I do? I didn't change the graft. I just did a PDEC with it, but my point was here below. Look, I did a 4th row pupillasty with PDEC and made that patient see. So saying this now, once you have seen this, we move to another very challenging situation, and I need to talk to you on that also just now. Okay, and this is a very interesting thing which we have just started, because since we brought out so much on fourth row pupilloplasty, look at this patient. Now this patient had high astigmatism, and unluckily for me it was actually after PDEC. The vision was 660. Okay, that was the astigmatic number. Now I didn't know what to do. When my doctors brought the case, they were wondering, what can we do? How do we solve this? So you get patients with high astigmatism, etc. What can we do? And I need to show you how to manage Phaconightmares of astigmatism. Watch the Purkinje image. This is Purkinje 1, which is the center. That is Purkinje 3. The one which is inverted is Purkinje 4. You will not see Purkinje 2. So now, what you do here is very simple. If you see the patient's astigmatism, look at that, 8.2 diopters of astigmatism. Now this is the chord mu, and I'll come to that a bit later so that it doesn't confuse you. But what is the principle I'm trying to do here? The principle, ladies and gentlemen, is I'm trying to make the pupil a pinhole. In other words, I'm going to make it a 1.5 millimeter pupil so that all the aberrations are cut, and this patient gets great vision distance and near without glasses. So you can see now there's a phenomenon. Why this is occurring is called the Stills-Crawford effect. I won't go into this in great detail, but a simple way, and I'm going to catch Gaurav's hand here, because if you see in the fovea, there are cones. Remember this. But if you see this hand of Gaurav, they are like a rod. And in the fovea, the rays of light have to hit the center. If they hit the side, the vision is not much. And that is the Stills-Crawford effect. And that's why the pinhole pupil works. So once we look at these reasons, you will see these patients with small aperture optics will have extended depth of focus. Another thing is, if I was taking a photograph of Aishwarya Rai, and I want to make her look beautiful, she's extraordinarily anyway beautiful, all I do is, in photographic trick, they'll make the periphery dark. This is called vignetting. In other words, we do this in pinhole optics. So, what is the message I'm trying to give everyone is, you have a patient which has got high astigmatism. You're wondering, oh boy, what do I do? Okay? They tried this in cornea with camera inlays. They don't work. Okay? They tried it with a pinhole IOL, which is pretty good. But what you have is, you need FDA approval. You don't get those lenses. They are piggyback lenses, the piggyback ones. So what we thought is, can we do this at the pupillary level? And you can see here, the idea is to make your pinhole pupil so that you get a 1.5 millimeter pupil. And that is the idea of the pinhole pupilloplasty. Now saying that, ladies and gentlemen, let's see the case. This was the case I showed you about. I've injected a little bit of viscoelastic because remember, there is an endothelial keratoplasty, so I don't want to damage it. We have made a pinhole marker, which is 1.5 millimeters. I always fix fluid. So you see that I've already fixed a simple trocar AC maintainer. I've got fluid in the eye. You can always keep on injecting viscoelastic whenever you want. Now, what is my game plan? Look at the Purkinje image. What am I trying? My pupil has to center around the Purkinje image. That is my basic game plan. So ask the patient, or you can center the face so that he's looking up at the light exactly, and the Purkinje image is bang there. Now I'm going to make that pupil smaller and smaller, but to my dismay, notice in this case, the pupil itself is decentered. Look, it's gone up. So I need to close this portion. Now you can keep on doing more and more of this single pass fourth row pupiloplasty because it's so simple and easy. So wherever I want, all I'm doing is I'm just keeping on doing the single pass fourth row pupiloplasty to make it like a pinhole. Now watch carefully. What I want to show you here is, look, I am now using a vitrectomy probe. So you need that, because sometimes either the pupil will become too small, or in this case it is decentered. It is decentered, the patient will not see. I am doing the vitrectomy to chew up that iris, and that's the big advantage, Gaurav, if you see the fluid in the eye. If you play, and I know Gaurav once told me he was doing this with viscoelastic, and I said, Gaurav, don't do this with viscoelastic. Play this game with fluid, you'll see the difference. Because if I play with viscoelastic, I can't do this. I need fluid in the eye to do my vitrectomy. Now look, it's become too large, but it has become centered. All I need to do is close this portion on the top. That's correct. Look, the pinhole marker tells me exactly where I am. My Purkinje image tells me where I am. Now watch, I'm doing some more and completing this case. So now, let's see at the end of the day, how did this patient behave? Now look carefully, ladies and gentlemen. Look at the Purkinje 3 dots which you see. If you have a Lumera microscope or any microscope you have, I'm making it matching that. And you can see now how it is bang on track. And that's what we are targeting. Once I have got this on track, now I suture up the wound there, take off my thing, and you can see there through the endolmeter also, my Purkinje image bang on track. Now question comes, how did this patient behave? So let's see that just now in a second, how this patient behaved on table, pre-op, on table. Day 1, remember, day 1, 2 weeks post-op, already the patient's vision has improved without glasses to 6/12. Did I make any cut in the cornea? No. Can it be done by anyone? Yes. Now, this is my specular microscopy, was pretty okay. That's why he was okay. One thing remember, what if I made it smaller? If I make it 0.5 millimeters instead of 1.5 millimeters, what will happen? The phenomenon of diffraction will happen. And watch this. If I make it 1.5, I'm on track. When I make it too small, ladies and gentlemen, the ray of light will start bending. This is diffraction, and my whole idea is lost. Now, very important for everyone to understand, the old terminology was angle kappa, where we were talking of angle kappas. But I tell you what, Daniel Chang and George Waring IV brought out this word called chord mu. And I was discussing with Jack Holliday on this topic. This is the pupillary axis. That's the visual axis which we are talking about. That's the optical axis. The distance here is the chord length mu. Now, if you take your pentacam, ladies and gentlemen, my idea in this pupilloplasty, what we are doing is, we are making it 0. So here you see that's an 8.2 diopters of astigmatism the patient is having. Now, if you see the chord mu of this patient, look carefully. This is the pupillary axis. That is the visual axis. See the distance? There is a lot of chord length mu in this patient. And you see now on here, that's the distance. Now look at post-operatively, I made it decreased. Now, I'm showing you on a picture, but can I show you on actual numbers? Look at that. If you see on your pentacam, there's a picture there called pupillary center, minus 0.7. There's a simple formula called Pythagoras Theory. All you need to do is go on your WhatsApp, on your phone, type Pythagoras Theory calculation online, it will calculate for you. You don't have to put your brain. Just put 0.7, 0.6, but simple way. If you don't want to do that, just add these through, it will give you 1.3. If you take a chord length mu, should be about 0.4, more than 0.4, patient is going to suffer. Now look at this is pre-op, okay? And Gaurav, post-op, look at that, it's about 0.1. So that's what is also coming out in the Journal of Cataract and Refractive Surgery, where we are showing the chord length mu is decreased. This is the Pythagoras Theory. If you just have to type Pythagoras Theorem calculation online, you will see, they'll ask you fill up A, fill up B, it'll give you the answer C. You don't have to put your brain, even my theory in optics is 0. That's why I got a person like Jack Holliday on board when we started working on this. Saying that, this I thought is a very important topic of pinhole pupilloplasty to show you. Now, since I've talked so much of Gyan on this talk, let's make this slightly more exciting and interesting and enjoyable also. Otherwise, it will get super saturated. So, here the fun begins, ladies and gentlemen. Okay, Iris, where have you been? So this particular case came to me and came like this. So I said, easy case. Okay? So I said, okay, easy case. Injury case, let me make him all right. Traumatic subluxated. So what I said, okay, all I do is, I'll fix it, make it all right. Now watch carefully. There is a small iridodialysis here. Okay, small iridodialysis, not a problem. I said, no problem, we'll make him all right. So I now say, what can I do? I did my vitrectomy. Now look, I'm stupid. Not only a dumb surgeon, but stupid surgeon. Now I could have straight away explanted those whole nucleus out. Okay, no. I want to think I'll do a gludial first. Then I will try to make it like a scaffold. Now you see how stupid I am. Now I'm doing this. I'm trying to do the vitrectomy, and after that I'm trying to implant the IOL behind the cataract so that I can make it like a scaffold, and I will be able to emulsify it without enlarging the incision. I am a glutton for punishment. Okay, now I'm doing my handshake technique. Gone, haptic went back. Watch carefully. You know why? That nucleus or the whole cataract pushes the IOL down. I didn't realize it. And obviously my haptic just went down immediately. So now I'm stuck without one haptic. So my second haptic I catch. And now I have only one haptic, ladies and gentlemen. This fellow will have also a drop IOL soon. I caught it, brought it out. Now I say, let me bring my second haptic out. So far, so good. Both haptics are out. But look, I told you before, I am dumb, stupid, and I'm lazy. At this stage, I should have understood my haptic will go back again because of the weight of this cataract on the IOL. Now what happened? I brought it out. Okay, so far so good. My cataract comes down. I'm about to tuck my first haptic inside. I search my second haptic. Gone. Gone with the wind. Now what do? Again I'm searching. Again I'm searching. How many times I'll do? The weight of the cataract is pushing this IOL down, dislodge this haptic. Now by the time I go in to pull out the third time, watch carefully, gone. Haptic gone. My brain already gone. Now what I do is shift back to my scleral tunnel incision, which I should have done before. But now watch this clip, because that's important for you, because I did not see this preoperatively. Okay, I'm extending the incision, and watch all of you, cataract is coming out. Look, I did not damage this. This was there before, okay? That small iridodialysis is not a small iridodialysis. That's a huge iridodialysis the patient had, which I had missed. And now watch. I'm just extending the incision to pull out the cataract manually, and you can see how it's coming out. Ah! Now what? I have got nearly half that iris out, iridodialysis. So now, like a stupid fellow, what I decide to do, I'm taking it off. Now small tag is there. No, I could have left it behind. No, I go and do vitrectomy. Oh, gone. And now I've got about 270 degrees of iridodialysis on my hand. Now what do? I am stuck because I have a broken glued IOL inside. Okay, I have my iridodialysis, which is a mess, fully there. So my first story is, forget the iridodialysis. Okay, let me take out the IOL. Okay, I'm now forgetting the iridodialysis. I can't forget about it. I will first fix my glued IOL with a new IOL. So you can see now, I'm doing that just now. Once I have done that, you see one haptic out. Now you see I'm fixing my second haptic out. So far so good. Iridodialysis is still there, don't worry. Okay, I'm not touching it. Now I start suturing because I don't want an expulsive tomorrow. Now I take my tunnel creation of Gabor-Chariot, tuck both haptics there. So far so good. Once I have done that, I will now try to repair it. So you can see this is the hang back technique. Simple way I want to show everyone. We are going to show this in the OPL also, but I'm taking a double armed, straight needle, Prolene suture going through the iris. Now it will come out from this side. That's one arm. Then I'll pass the second arm. Both arms will be pulled and tied. This technique was started by Michael Snyder from the Cincinnati group in the United States, and I think it's a great technique which was started. So once I have done that, you see now subsequently I've got a portion of this fixed. Now I continue doing this all around as much as possible. But remember, ladies and gentlemen, when you do a hang back technique, it pulls the iris out. So in other words, the pupil gets distorted. So what you need to do is combine this now with single pass 4-throw pupilloplasty. So again the animation, if you notice here, you can see that needle coming out like that. I bring this loop out, 4 throws. Now you all know that game in and out. So in other words, what am I going to do now is single pass 4-throw pupilloplasty and seal it. So that patient who has got the hangback technique, now I will do my single pass 4-throw pupilloplasty. And don't ask me how many hours did I operate. Please ask me how many days I operated on this patient. Okay? Because you can imagine I was up to my neck in trouble. But slowly and steadily, you will see in this case that pupil coming back to shape. Remember the 270 degrees which the case had? Now you can see how the patient is looking at the end. Here you can see on the animation, again showing the single pass 4-throw pupilloplasty. Our new book is coming out with Slack, with Dr. Ashwin and me are doing on iris repair, and it should be coming out at the American Academy, showing all these techniques. And you can see here, again look at that. That's the iridiolysis. I've taken the hangback technique, straight arm throughout. Now take the second straight arm out. Tie both, that closes. Now let's see the post-op picture, ladies and gentlemen, how this patient looks for want of time. We'll see how the patient looks now. That's post-operative day 5. Vision improved to 6-9 already. You can remember on table how it was, post-operatively how it was. 1 month post-op, you can see how the vision has improved to 6-6. Saying that, I thought I wanted to talk to you on another very, very important topic, because it's important for us to see whether we can combine all these dots and make some crazy case pretty okay. If you see in this patient there, look at the scarring. This patient was operated in the United States and had a lens AC IOL implanted. But look at the scarring there. So I knew there's an AC IOL inside the eye. I've made my scleral tunnel there. I'm taking off that epithelium because it's so bad. Once I have removed it, next step for me is to fix my trocar cannula. Now watch carefully. I am going to make my flaps 180. That's very important. Those flaps got to be 180. The advantage in glued IOL I need to tell you is the flap seals everything down. I'm doing the vitrectomy. Once you have done the vitrectomy, I always do vitrectomy in such case because I do not know what the previous surgeon has done. So now you see at the end of it, I'm going to explant this anterior chamber IOL. Once I explant this IOL, I'll be safer. But remember, the problem in these AC IOLs are, they are stuck to the iris there. So you see there, I'm just going to pull them slowly out, one by one. Once I've done that, remember the haptic is broken. So now I will pull out my other haptic here. And then there's still one more stuck to the iris. So when people say we can put an anterior chamber IOL, I suggest to people you might be better off doing any other technique, because sometimes an anterior chamber IOL can do well, but sometimes we can get into trouble, like in these cases with bullous keratopathy. Here you can see now, once that's done, I now go ahead and do my glued IOL. So what did I do first? I did my AC IOL explantation, ladies and gentlemen. We are now doing the glued IOL. Now you know this very well. So simple it is. First haptic out, handshake technique, second haptic out, and that's simple. Once you have done that, remember, I want my pupils small for 2 reasons. One, I don't want my air going back because my graft will remain in the front. Second, I'm going to try to make it like a pinhole pupil so that tomorrow I don't have an astigmatic problem. So now I'm going to do the single pass 4th throw pupilloplasty just like what I showed you just now, and you can see me subsequently doing that. Once you have completed this 4th throw pupilloplasty, you have made the pupil small, plus the chamber remains nice and solid. The IOL, which is a glued IOL, works like a tamponade, pushing the air up. So you see that just now. Now we move to the next step of the procedure, which is PDEC or pre-Desmaze endothelial keratoplasty. We don't do D6. We don't do DMAX. Why? In DSEC, you're taking about an 80 micron cornea. Okay, it's a problem. In DMEC, you take 15 micron. But the problem is, the donor, if you take, is stuck to the stroma till the age of about 40 or 50. In PDEC, watch carefully, I'm making a type 1 bubble. Now, I perforate this. This is just 25 microns. But any age. I can play with a 1-year donor, 5-year donor, 20-year donor, and I was talking to Namrata Sharma. She has started moving to PDEC, and she was telling me the advantage being that in AIMS, they have a lot of young people who get road accidents and they can get those eyes out from young people. Now I'm doing my endothelium removal. Once that's done, I will inject this graft, and for fast forwarding the time, I will now just show you how we inject the graft, and then let's see the picture of this particular case, how the case looks when it is unrolled. And you can see we are just unrolling this graft. That's how the case looks. Now, ladies and gentlemen, let's see post-operative picture. So let's see how this patient looks now at the end of the day, and you'll see me subsequently showing it to you pre-op and post-op. You can see that 1 month post-op, 2 months post-op, 6/9, and you can see 3 months post-op, 20/20. Look at the pre-op comparison, and 9 months post-op, the patient's vision improved to 6/6. The last 1 minute clipping I thought I'll keep, and Gaurav, can you keep your thing? Is Suhas here? Oh, I don't see you. Suhas, come here. Okay, this last one, it's a 1 minute clipping which I thought I'll move. And this is important for you to see in this thing, because this is 2019. And we have a lot of hospitals in Africa, and I see Dr. Amelia is here from a great center in Mozambique. But the issue, what I wanted to show this is something which perhaps many have not seen. This is in 2019, and my doctors had gone and seen it. And look at this, couching. In today's world also. It's happening in Kaduna in Nigeria, and you can see the surgeon, or you can call him the so-called surgeon, touching the wall also, clearing it there, and you can see how bad and traumatic this is. So ladies and gentlemen, lot for us to learn and try to see whether and how we can improve. I'd like to thank Gaurav and Suhas, who are now going to speak to us. Gaurav? So anyway, thank you very much, ladies and gentlemen.